When we think of the role of a physician, we probably picture that person speaking with a patient. Maybe we imagine them eliciting a history, conducting a physical exam, or making and communicating a management plan. What we probably don't picture is that physician working alone at the computer. But this is increasingly a part of medical work, especially in family medicine, which in some countries is known as general practice. Approximately half of a family doctor's time is spent doing what we call indirect patient care activities. Indirect patient care activities include things like documentation, dictation, billing, filling out requisitions, reading and writing consult letters, prevention reminders, updating the chart, filling out forms, reviewing and managing investigations, and refilling prescriptions. Indirect patient care activities, or IPCAs, occur in most specialties, but they are particularly relevant to family medicine because the family doctor often ends up reviewing and managing tests, investigations, and prescriptions ordered by other specialists. IPCAs are an essential part of patient care. This is work that needs to be done. Sometimes it can be done synchronously when the patient is present, but not always. We know that IPCAs take up approximately 6 hours of a family physician's day, and that about an hour and a half of that time occurs outside of typical business hours of 8 to 6. This increase in time on IPCAs has been impacting the quality of professional life. Studies have identified increasing IPCA work as a contributing factor to burnout. For example, those who spent more than 90 minutes a day after hours on the EMR were at 3 times the risk of burnout. As medical educators, we are left with a practical challenge. IPCAs are an essential part of patient care, and they're not going away, but they're hard to balance against all of the other competing demands, and they place physicians at risk of burnout. What can we do in training to best prepare resident physicians to take on the realities of clinical practice? That challenge was the guiding ethos of this study, in which we interviewed 3 stakeholder groups involved in family medicine education, asking, how do family medicine residents, recent graduates, and clinical supervisors perceive the educational impact of indirect patient care activities? In Canada, where this study was conducted, we use the term resident physician to refer to physicians who have completed their medical degree and are working on clinical training in the specialty of their choice. We focused on this type of trainee because residency is typically the career stage that trainees fully encounter IPCAs, and they often come as a rude awakening. In one survey of resident physicians, 90% of respondents indicated that the documentation requirements were excessive and compromised time participating in direct patient care. Learning how to absorb these tasks alongside their clinical work and learning is a challenge. We used a constructivist grounded theory approach and conducted the study in a single residency program. We recruited learners, alumni in the first 5 years of their clinical practice, and educators. Some of the physicians in the first 5 years of practice were also educators. We gathered data through focus groups and interviews, and we used all of the typical grounded theory techniques, such as theoretical sampling, iterating data collection and analysis, and refining our focus as the project progressed. Our final sample included 19 residents, 16 early career physicians, and 7 educators. We tried for diversity in gender experience and whether they worked at an academic or community site. The majority of our participants were women, which is reflective of the gender distribution of this specialty. Our research team included several family physician educators and 2 qualitative researchers who are not physicians. Data was collected by Marina Sadek and Meredith Vanstone, 2 qualitative researchers who do not have a role in resident education or assessment. Our participants agreed on a few important points. Everyone we spoke to recognized that IPCAs are a necessary and unpleasant part of family medicine. They recognize the essential nature of IPCA work to the provision of patient care, but also describe this work as never-ending and a crushing responsibility. The groups differed on how they talked about the nature and impact of carrying this weight. Residents and those in their early career described the weight of IPCAs as a burden. More senior participants described carrying this weight in residency as an opportunity to develop the strength needed for a sustainable career. We'll describe these differences in more detail and point to some contributing factors that might help us understand what influence these views and how we might move together into an optimal way of incorporating IPCA education into residency training. First, the weight of IPCAs as a burden. We heard this attitude mostly from residents. They felt that this burden impeded their learning, work-life balance, wellness, and ability to achieve other educational goals.
Monitoring the inbox provided me way more stress than any educational value.
The learning curve of clinical medicine alongside the development of practical skills needed to manage the IPCAs was taxing.
It really burnt out a lot of my co-residents in their first 6 months of residency when they didn't know anybody. They didn't know the system, they didn't know the program, they didn't know how to be a resident, and also how to do an inbox of 1,000 people at the same time.
We noticed that residents who described IPCAs as additional work tended to talk about themselves as students first, emphasizing their own learning and the way that IPCAs prevented that. Participants who described IPCAs as a learning opportunity were more likely to think of themselves as an apprentice to medicine, with IPCAs being an expected component of care instead of just administrative work. Here, we can see the influence of the developing professional identity of residents who are transitioning from learner to clinician.
I think it depends on how you actually present it. Like, this is not about you doing my work, but this is about me providing you with a different kind of education that in the end will make you a good family doctor.
In contrast, more experienced participants talked about the weight of IPCAs in residency as an opportunity to develop the strength needed to develop a sustainable career. They viewed this work as an extension to direct patient care and an integral part of their jobs.
When you complete this form, you are giving your patient access to funding or resources or whatever. You are helping your patient every bit as much or maybe more than when you're sitting face to face with them.
They recognized that residency provided opportunities to develop strategies to effectively and efficiently perform this work.
There's obviously a finesse to ODSP forms. It sounds silly to say, but there is an art to filling them out, and learning those things as a resident is helpful. I'm glad that I spent time as a resident figuring that stuff out and busting my butt. It reduced the burden when I became staff.
Looking back on their careers, they saw the development of a sustainable strategy for managing work as an essential part of learning how to be a successful family physician.
More important than that is making sure we can all do the marathon and that we don't burn out and compromise our health and wellness in the process.
Participants also described factors which could exacerbate the burden of IPCAs or alleviate that weight. Exacerbating factors included ambiguous expectations, described the work that medical trainees often do to quickly understand the implicit goals, priorities, and processes of their supervisors. Supervisors with their own practices are not always aware of their own idiosyncrasies, and so seldom provide explicit and consistent instructions. Perceptions of inequality of IPCA workload amongst peers was also identified as an exacerbating factor. Some participants perceived that they got dumped on with much more IPCA work than their peers or than their supervisors. They were also acutely aware of differences in resources available to do this work, like delegating follow-up appointment calls to a staff member. This feeling of injustice exacerbated the burden of the work. Finally, we heard about competition between the dual roles of either learner-clinician or teacher-clinician. Whether a learner or an educator, these physicians were often trying to do two things at once, and getting IPCA work done felt in particular tension with the ways they wanted to spend their teaching and learning time. Understanding these factors, we recommend standardizing resident involvement and expectations for IPCAs. Transparency about what the workload is like in community practice and sharing strategies about how you personally manage these tasks could help address some feelings of inequity amongst residents. Many of our residents thought that they were doing the IPCA work for their supervisors. Educator data did not agree with this perspective, describing the extra time, patience, and flexibility it took to coach the learners through IPCA work. The educators reported that any lightening of the load experienced by resident contributions was typically offset by extra time needed for teaching, double-checking, or redoing work done by novice learners. Residents recommended that programs provide learners with protected time to complete IPCAs. This dedicated time would help account for the additional time residents require to accomplish the work they are still learning how to do. Educators were less supportive of this, recognizing that part of the learning opportunity is to develop strategies to keep this work manageable, and that when in independent practice, dedicated time means a loss of income. Alleviating factors included formal teaching, a graduated approach to assuming IPCAs, familiarity with patients, the resources of the clinic, and local resources. These helped that wait feel more manageable and facilitated participants recognizing opportunities for developing sustainable strategies for practice. A graduated approach means a slow introduction, gradually adding on additional components. Residents believe that this would help relieve stress as they focus on the clinical aspects of care. Participants also felt that a graduated approach would facilitate more effective and efficient learning about IPCAs. A number of our participants, both residents and physicians in their early career, talked about ways to minimize IPCAs by changing the structure of their practice. For several people, this meant decreasing their involvement in traditional comprehensive family medicine and instead engaging in focused practices such as hospitalist or emergency medicine. This is a way to alleviate the burden of IPCAs on the individual, but it will result in a gap in care if family physicians start moving away from generalist practice to escape this type of work. The desire of residents to move away from comprehensive family medicine is concerning, given the importance of generalist primary care to access the health system. This change is already visible in the system, where we have seen fewer family medicine graduates choosing to practice comprehensive family medicine, coupled with a declining activity level and patient panel size in those who are doing this type of medical practice. Helping residents learn to sustainably manage this work may be an important part of health human resource planning to ensure the sustainability of our primary care system. This study has therefore highlighted the need for new curricula to help prepare residents, especially family medicine residents, to manage their practices, integrating this vital piece of patient care while being mindful of competing demands. This curricula would include transparency about the existence of IPCAs, the anticipated workload, expectations, and strategies for sustainable management. In conclusion, IPCAs are a necessary and increasing part of family medicine work, and it is essential to ensure residents are prepared to manage these tasks in an effective and sustainable manner. Without a focus on sustainability, IPCAs risk becoming a barrier to recruiting and retaining sufficient numbers of generalist family physicians to meet population needs. Achieving this will require education, innovation, and change. Failing to support in this area carries the risk of more challenging transitions to independent clinical practice for graduating residents, and for some, attrition out of comprehensive care and into subspecialization. That said, education innovation alone is not sufficient. An undercurrent of this data was the increased physician workload resulting from widespread implementation of electronic health records and without corresponding remuneration. Policy implications of this study include health system change, which increases the sustainability of family practice.